Dr. Marcos and Dr. Sami. It truly is an honor to be included as part of the panel. Quite honestly, can you hear me now? It's humbling to be speaking in front of a bunch of surgeons that I've grown up watching and learning from. And what I thought I'd focus my next sort of 10 to 15 minutes on is really just sharing some data from our own program in the literature regarding the management of recurrent meningiomas post-radiation therapy. I think this is a problem that we all face. And, certainly with myself, sort of 10, 11 years into practice, often struggle trying to figure out what the right thing to do is with patients that have been heavily treated with surgery and radiation before, and trying to honestly counsel them with regards to expectations. So there's an example of a patient I treated several years ago, a lady who had a atypical meningioma, had a debulking operation, was started out as a middle fossa meningioma, and then treated with CyberKnife radiation therapy. And about a year after her radiation therapy, essentially presented with pretty significant disease progression. You can see into the infratemporal fossa, the sphenoid sinus, the pterygopalatine fossa, and of course the middle cranial fossa. And of course, the surgeon, all of us, wants to sort of jump in and take this out. And then, of course, the patient, being a very educated patient, really asks, what are the expectations of treatment in terms of the expectations of doing a repeat operation, and then how effective that's going to be with or without radiation therapy. Is there room for additional radiation therapy? And then, what's out there in terms of systemic therapy? And I think similar to, surgery where you can have a subtotal resection, but then achieve a gross total resection, that often comes up with re-irradiation therapy where patients perhaps were inappropriately or inadequately treated the first time around, and there's more room for additional radiation therapy. And so, for quite some time, I think there was, at least from my perspective, data lacking in terms of that decision-making. And, when you look at the challenges with managing recurrent, previously radiated meningiomas, the challenges are numerous. And these are, 3 examples of patients I've treated more recently. They're anatomically complex. As you can imagine, they tend to involve the middle fossa, the cavernous sinus, or the petroclival region. They can be multifocal, high volume, low volume, and then, varying degrees of resection have been performed before, and varying degrees of radiation therapy. And then, of course, with a quote-unquote benign disease, quality of life is a big expectation with this patient population. And certainly I've learned the hard way with some patients who told me they've regretted doing their 3rd or 4th operation.
Can I interrupt you for a second, Dr. Singer? If you're in the audience, please come and connect your laptop.
And so, certainly the regrets that happen over time. So what I want to do is just take you through the data behind repeat surgery, re-irradiation therapy, and highlight some of the newer systemic therapy agents. And so, there's a patient I treated with a optic nerve sheath meningioma who had failed radiation therapy, which certainly would be first-line treatment for a tumor like this, and she presented no light perception. Certainly, a tumor they think can get a gross total resection on, which it did. And what the data shows when you looked at our own experience recently in the setting of previous radiation therapy is that getting a gross total resection still has a significant impact on local control rates. So it sort of makes sense for a recurrent grade 1 meningioma who's failed radiation therapy to go ahead and put him through a gross total resection. Now, what about a recurrent atypical meningioma like this patient on the top left? And presented to me and essentially started out as a hyperostotic sphenoorbital meningioma, but there was disease within the sphenoid wing and the periorbita that was extraconal in nature that was left behind and radiated, and that essentially progressed. And certainly, I resected the bone and resected all the intraorbital disease that was extraconal. And looking at our own experience, what we found with recurrent atypical meningiomas in the setting of previous radiation therapy is that getting a gross total resection has an impact on local control rates. And sort of breaking down it even further into Simpson grade, that shakes out in terms of there's a difference in outcomes between Simpson 1, 2 versus 3 and 4, which highlights that I think this is a much more invasive disease process than we think it is, and that GTR simply may not be enough, but trying to sort of chase after those dural margins when possible is also meaningful in this patient population. Now, what about recurrent anaplastic meningiomas? These patients who have had a subtotal resection, perhaps initially treated as a grade 2 meningioma, but presenting with a massive recurrence like this one on the left side, and certainly, able to get a gross total resection in this patient. The data in our own experience, what it found is that getting a gross total resection didn't seem to have an impact with the recurrent anaplastic meningiomas when they failed surgery and they failed radiation therapy. Again, truly a malignant disease process. Now, from the salvage surgery perspective, what are the considerations? When we look at the anatomic sort of shakedown of the nearly 600 recurrent meningiomas we treated in our own practice, nearly half of them are middle fossa meningiomas, and the remaining sort of split between anterior, middle, and posterior fossa. And when we look at the middle fossa recurrences that occur, as you can imagine, a lot of these have bony invasion of the sphenoid wing and the floor of the middle fossa. A good number of them have cavernous sinus invasion, and a good number of them have infratemporal fossa invasion. And so with these recurrent sort of previously rated meningiomas that are middle fossa in nature, they tend to be multi-compartmental in nature. And certainly with this audience, I'm not going to sort of go on the technical sort of nuances needed to take out these tumors. I figure I just highlight sort of 3 of the lessons that I've learned over the years as a young surgeon that have helped me trying to figure out what the right thing to do is with these resections, and really focusing on perioperative adjuncts, the importance of multi-compartmental approaches, and really paying attention to reconstruction strategies. So one lesson that I've learned is in the previously radiated and operated setting where there's a lot of scar tissue and then radiation changes in the bone, sometimes the MR imaging may not be accurate in terms of estimating the true extent of disease. And so certainly I've been bitten by going into a case thinking that, oh, the disease is very limited, I'm going to get a gross total resection, when, as a matter of fact, the disease was much more extensive, and vice versa. And so on the left, for example, is a patient of a radiation-induced meningioma who had a childhood malignancy. And you can see sort of this extensive disease involving the sphenoid wing, infratemporal fossa, going down into nasopharynx. And on the MR, you could convince yourself that, maybe I'll do subtemporal, infratemporal fossa, or maxillary swing in order to get what would seem like a gross total resection. And what I found is using dotatate PET, which sort of binds to somatostatin receptors, actually helps give you an idea of perhaps the invasiveness of the disease process. And in this young patient, you can see there's disease involvement of the contralateral pterygoid process. So the bony disease is much more invasive than you would think it is. And then also where I find dotatate PET helpful is really assessing the extent of bony disease involvement. So on the right, for example, is a patient with a recurrent previously radiated sphenoorbital meningioma. And in the bone, because of the radiation changes, it was really hard to figure out if there's real disease there and I need to resect the frontozygomatic process and reconstruct it, or can I get away without doing anything with it? And it lit up on the dotatate PET. So that'll help me with planning the extent of bony resection and certainly the implant that was needed for the reconstruction. And then, the role of 5-ALA. Several years ago, there was this trial looking at 5-ALA for newly diagnosed and recurrent meningiomas, and our site participated in this. And, what I learned with that process is that there, certainly is a utility of 5-ALA for the recurrent high-grade meningiomas when you're trying to figure out intraoperatively how much sort of the dural tail to chase and the disease to chase. And then multi-compartmental access. This is an example of a recurrent patient I treated. On the left here, you can see there was a lot of sort of bony disease that was left behind with the original operation that was radiated and essentially recurred or progressed and extended down to the infratemporal fossa. And so with a lot of these cases, sort of using these multi-compartmental approaches where we did a subtemporal infratemporal fossa approach and a lateral temporal bone resection, essentially resecting everything lateral to the facial nerve and the cochlea and the semicircular canals, allowed us to get a much more extensive bony resection along with the soft tissue disease into the infratemporal fossa. And then reconstruction. Certainly with the reoperative setting, the risk of complications are high. And when we looked at our own experience, we tend to look at complications according to severity, where the type 1 complications are those that are managed medically, type 2 complications are those that require some sort of intervention, such as take back to the OR or lumbar drain placement. Type 3 complications are those that result in sort of organ failure and ICU admission. And you can see that a majority of the complications that we face are medical complications, but the complications that required some sort of intervention are mainly wound related. And on the right, highlighting this paper from Mike McDermott's experience, looking at an extensive experience with recurrent meningiomas. And they did a really honest assessment of their ability to get a gross total resection and really what their complication rates were. And what they found was a 33% complication rate. And the most common, as you would expect, were really wound-related and CSF-related issues. And so this highlights sort of, being obsessive compulsive about the reconstruction before you find yourself with a big defect and with radiated tissue. And so highlighting sort of the importance of bony reconstruction. There's an example of a recurrent sphenoorbital meningioma where I resected the bone and the orbital component of the tumor, and you're left with a defect like this. And this is really where using these custom implants designed to the defect are helpful. And in the radiated setting, just being obsessive about ensuring that this vascularized tissue covering the implant and of course separating it from the paranasal sinuses and the subtemporal subcranial space. And then with these more larger defects, such as this large infratemporal fossa resection showed you a little bit earlier on, these defects can be high volume, and so relying on our plastic and reconstructive surgery colleagues to do free tissue transfer, even in a quote unquote benign setting, we find has been helpful in terms of reducing that risk of wound-related complications. And of course, the nuances are numerous when you're dealing with these more extensive anterolateral recurrent meningiomas. Now, what about reirradiation therapy in the setting of someone who's failed previous radiation therapy? And so, we have experience with over 73 patients where the feeling was that their first round of radiation therapy was inadequate. And because of the biology of the tumor, either high Ki-67, atypical or malignant nature, that there was a need for reirradiation therapy. And you can see most of the time when we're doing reirradiation therapy, we're relying on sort of a VMAT, sort of more of a fractionated approach to really reduce the risk of complications. And what we found is that certainly there's a benefit to reirradiation therapy with the recurrent atypical meningiomas that have failed subtotal surgery and radiation therapy, and similarly with the recurrent anaplastic meningiomas. Now, this comes at the risk of radiation complications in nearly 15% of patients, which is twice that risk versus radiation naive patients. And so this really highlights the importance of systemic therapy. And I think we all know that really systemic therapy, there isn't a single proven effective systemic therapy agent out there. And looking at the outcomes reported there, the outcomes that are used are 6-month progression-free survival, which we think, I think we would all agree is a pretty low expectation for a systemic therapy agent in a meningioma patient. But, one of the agents that we more commonly use in our practice is octreotide and everolimus. And when you looked at that data, only 44% of patients had stable disease at 6 months after surgery. But when you dive deeper into that and looking at the NF2 mutated patients specifically, 68% of those patients had significant disease stability with octreotide and everolimus. And so this has been one of our go-to agents for these recurrent previously radiated meningiomas, where we know we have to add something else on because of their disease biology. And this is an example of a patient of ours treated with that, showing disease stability after having had disease progression with multiple rounds of surgery and radiation therapy. And then, of course, all the rage in cancer right now is immunotherapy. And, what we've demonstrated is certainly this increase in expression of these immune markers, PD-L1 and PD-1, with higher grade meningiomas, grade 2 and grade 3 meningiomas. And so this is the basis of an ongoing clinical trial at our own practice looking at checkpoint therapy for these recurrent tumors. An example of a patient who presented with this progressive falcine and parasagittal meningioma with a patent sinus and ultimately disease stability on Pembro. Now, what's a little bit more interesting is really the role of Lutathera. And this is an abstract that was actually just published last week. And what Lutathera is basically targeted radiation therapy. It's a radionucleide that binds to somatostatin receptors and was initially introduced for neuroendocrine tumors. And so what this phase 2 clinical trial did was looked at Lutathera for recurrent grade 2, grade 3 meningiomas. And what they found was a 6-month PFS rate of 78%, which is certainly much better than any other systemic therapy agent out there with much less toxicity. And personally, I've had about 3 patients treated off-label with Lutathera because they were ineligible for further radiation therapy. And so it'll be interesting to see how this story shakes out over time in terms of how we think about, perhaps radiation therapy for recurrent or newly diagnosed meningiomas where the risk of radiation toxicity is high. So just wrapping up here with my last minute, I started out with this patient here. So what did I do? I did a hybrid approach. So I did a subtemporal and an endoscopic approach to get a near gross total resection. Being honest, I left a little disease there along the inferior aspect of the cavernous sinus. It was a grade 2 meningioma, and we got a dotatate PET, nothing else lit up. It was just that area in the cavernous sinus. And so we just did a single session stereotactic radiosurgery to that area. So, in summary, what I just wanted to do was just share some of the lessons that, I've learned in my short career in terms of managing recurrent meningiomas and highlighting some of the data that's been published regarding, I think, this disease entity that we all face. So, thank you again very much for including me as part of the session today.